Perfect. I want to thank everybody for waking up so early to come see us today, and I want to thank SAGES for the opportunity to present our work. My name is Sahil Sharma. I'm a fourth-year general surgery resident at McMaster University, Canada, and this project was done in supervision with Dr. Guman, who is a colorectal surgeon at the University of British Columbia. Our project is titled Postoperative Recovery of Colorectal Patients is Enhanced with Dexmedetomidine, also known as PReCEDex, a systematic review and meta-analysis. Myself or any of the study authors have no relevant disclosures. So we know that transient impairment in postoperative bowel function is commonplace after elective colorectal surgery. However, prolonged postoperative ileus, defined as a delay in passage of bowel movements by greater than postoperative day 3 to 7, still occurs in approximately 1 in 10 patients. In addition to abdominal pain, it leads to nearly doubling of the patient's length of stay and costs the American government $1.46 billion on an annual basis. The pathophysiology of prolonged postoperative ileus is hotly debated, but we know that it begins sometime after the manual manipulation of intestine intraoperatively. This leads to macrophage-mediated smooth muscle inflammation, which, when combined with postoperative sympathetic activity, impairs intestinal transit. Dexmedetomidine is an alpha-2 adrenergic agonist, which is known to have anti-inflammatory and anti-sympathetic effects in the postoperative period and is therefore postulated to enhance the recovery of colorectal patients. Therefore, the aim of our study was simple. We wanted to investigate the effectiveness of dexmedetomidine on postoperative gastrointestinal recovery following colorectal surgery. We did so by having one of our study authors, who is also a trained research librarian, ask a simple question. What is the effect of dexmedetomidine on postoperative gastrointestinal function in patients undergoing elective colorectal surgery? We posed this question to 4 large databases, including MCare, Central, Embase, and Medline. Our inclusion criteria included all randomized control studies, which were looking at elective colorectal surgery patients having intraoperative dexmedetomidine versus those undergoing an analogous procedure having a control substance. In total, we had 1,194 unique abstracts that were reviewed, and at the end, 8 randomized control trials met our inclusion criteria and had 1,126 colorectal patients. And as you can see, they were quite evenly distributed between the dexmedetomidine and the control group. Specifically, we had 570 patients in the dexmedetomidine group and 556 in the control group, and the rest of the demographic variables were quite evenly distributed. In terms of the route and the method that dexmedetomidine was given, 5 of the 8 studies used an intraoperative bolus followed by an infusion. 1 study used an infusion throughout, and 2 studies delivered the drug via an epidural. In terms of the method of the surgery, 5 of the 8 studies used all laparoscopic procedures. 1 study used all open procedures, and 1 study had a combination of 2, and lastly, 1 study failed to mention how the procedures were completed. In terms of our primary outcomes, as you can see, we found both a clinically and statistically significant benefit in using dexmedetomidine. Specifically, there was a 14.5-hour shorter time to first flatus and an 11.9-hour shorter time to first bowel movements in the patients who received intraoperative dexmedetomidine. In terms of our secondary objectives, you can see that there was again a clinically and statistically significant difference. There was a 14.3-hour shorter time to first solid oral intake, and all of this resulted in greater than 1 day less in hospital for these patients. The implications of this are vast. We know that 10 to 30% of elective colorectal surgery patients have an element of postoperative paralytic ileus, and having a medication that can help enhance their postoperative recovery means that you are benefiting a large proportion of patients. Secondly, depending on which study you look at, 1 day in hospital can cost anywhere from $1,300 to $4,200 US per day, and reducing 1 day in hospital for each one of these patients leads to great cost-benefit savings. So we have a medication that has both tangible benefits for the patient population and for the healthcare system as a whole. But again, no study is without its limitations, and our limitations stemmed from the variation in administration protocols. Some studies delivered the drug via an epidural, some delivered it via an intravenous, and also the dosage varied anywhere from 0.2 to 0.6 micrograms per kilogram per hour. And lastly, perioperative management. As was mentioned earlier, after one of the participants' talk, that ERAS protocol has shown to lead to better postoperative bowel recovery. And of this 8 studies, only 1 mentioned ERAS protocol or even how patients were managed postoperatively. And that 1 study said that they specifically did not use ERAS. So in conclusion, we know that there are considerable clinical and statistical benefits to using intraoperative dexmedetomidine, including improved postoperative gastrointestinal recovery and earlier discharge. Where I see this study and this information going future is we want to standardize dosing regimens, and we also want to conduct a cost-benefit analysis of the routine use of this drug in all elective colorectal surgery patients. I thank you, and I welcome any questions.
Thank you very much. Do you have any numerical or any quantitative statistics about the heterogeneity of the studies? I know you pointed out some of the important ones.
Yeah, so in terms of the I-squared variable, and we also did a grade analysis of all our recommendations, and there was a fair bit of heterogeneity within the studies, and a lot of that also stemmed from in terms of the control substance the control agent that was being used. So some controlled it to a saline infusion, and some compared it to standard care, which could have included something like a remifentanil, a sufentanil, which are also known to have effects on bowel recovery. So our I-squared statistic varied anywhere from 25 to 60%, depending on which variable we were using at.
Thank you.
Now, one quick follow-up question. In the advent of ERAS, with same-day discharge for patients, how does this particular drug, PReCEDex, how does it factor into reduction of length of stay and also the cost of care?
Yeah, for sure, and I think that's a great point to bring up. In terms of a lot of the same-day discharge studies, I think from what my knowledge is, a lot of the preliminary data is coming from studies such as ileostomy reversal and in programs that have a network in the community where these patients can be followed afterwards in the community as well, should they have any question. A majority of the procedures that were conducted in these randomized controlled trials were either left hemicolectomies or rectal cancer surgeries, and for those, I don't believe there's that much data out for same-day discharges.
Very good, thank you.